It's our 8th session of KSOS PG classroom. So we were alternating between case-based discussions and investigations. Today we'll be having our second session of corneal topography, and we'll be going through different images of corneal topographies, and there will be discussion based on that. Anil sir, can you please introduce? Anil sir is Dr. Anil Radhakrishnan is the senior consultant in Amrita Institute. He'll be introducing the faculty and our PGs.
So due to technical issues, Dr. Ritu Arora could not join. But we have a very eminent person who's a good friend of mine, Dr. Srivalli. She did her fellowship in LB Prasada Institute way back in 2002 or 3, when we were together. Then she went on to work in multiple places and had a pretty long stint in UAE, then came back now she's a faculty in Shankar Nethralaya, Chennai. And as a part of cornea services, she is definitely involved in residence teaching and cornea-related work. I don't want to go into her medals and trophies and all that, but it's suffice to say that she's well versed with corneal topography and all the different machines she has used, and she would be the best person to describe about corneal topography. I think for today's session, we will have a brief presentation by Srivalli, then followed by a case discussion. So case discussion would be handled by Yash. Yash, you can run through the slides, and if there is an issue, I can do that also.
Sure, sir.
So I think the focus is basically imparting the knowledge to the postgraduates, residents, or fellows, whoever it is, and help them understand exactly what is the topography. Quite often people are scared by these colors and all that, and they follow some vague, some quite often incorrect perspective they have got. But it's very important to have proper information about this if you want to interpret it correctly, just like visual fields. So over to Srivalli.
Good evening, everyone. Hi, Anil, and thanks for that introduction. So welcome to all the PGs, and this is the part 2 of the session that we are doing. So actually, we're not going to have too many presentations. Dr. Anil gave a very good presentation in the 2 weeks back when we had the part 1, and I hope all the postgraduates had understood all those small, nuances which were told very nicely by Dr. Ritu Arora last time. This is like a quick recap, just because 2 weeks is a long time sometimes and we tend to forget, right? So the first few slides are a repetition of what we did previously. And then we'll just go to some images just to make sure that you people are understanding. So please feel free to answer and to stop and ask if you have doubts, because only then we will know whether what we are saying is reaching across to you or not. So the idea of this class is to make you comfortable with reading a pentacam, or just at least coming to know that what is this and whether you should be referring this patient or whether you should be, not be worried about it. Right now, as postgraduates, you may not be directly doing the surgeries or the management part, but at least like when you finish your exams and you're practicing alone, you should be able to confidently say, look at a report and say whether it is normal or it is not normal. Something is definitely, it's going towards an abnormality and I need to investigate more. Okay. So I'll just start with a small presentation. My slides are visible?
Srivalli, this Komal and Harun are from your place, or?
Maybe.
Okay.
Because I sent, we can ask them, because I'm also.
Yeah. Maybe after your presentation, they can come. Maybe they can get ready and come.
Yeah, sure. I mean, I just sent it saying anybody who can join, so please join. So I don't know how many people are getting that link.
Yes, ma'am, we got it, so I've joined. This Komal here.
Oh, okay. Hi, Komal. So yeah, once we get to the postgraduates part, do introduce yourselves also, all of you, whoever has joined. Okay. So my slides are visible. Can I start?
Yeah, sure.
Yeah. So as I said, this is just a very, very brief recap. So
And slides are not visible.
Not visible.
not visible.
No, ma'am.
Now are the slides visible?
No, ma'am. It's not.
No.
Stop the video. Visible now?
Yes, ma'am.
Yes, ma'am.
Yeah.
Yeah. Right? You can see the full slideshow.
Yes, we can see.
Yeah, so as I said, this is just a very quick recap. We stay in a lot of instant times. We don't really have too much time to sit and go into the very much detail. So it's like an instant pizza delivery, and we'll try to make sure that within 30 minutes you people are knowing about Pentacam. The corneal investigations, Dr. Anil had dealt with these things in very much detail. Just to mention once again, when we say topography, the term is mainly based, is for the placido disc based investigations. And when we say tomography, then we are talking about both the anterior and the posterior curvatures of the cornea. So the slit scan, and basically OBSCAN uses a slit scan to see the anterior and posterior, but it does not see the posterior completely. Whereas the Scheimpflug imaging, which is the Pentacam, Galilei, or the Sirius, are the ones which are actually more accurate as far as the posterior surface is concerned. The ASOCT is a newer tool which also has its own advantages. There is a further dimension called Corneal Biomechanics, which is the Corvus is the machine, which I will just briefly touch upon to let you know the newer things that are being done in keratoconus screening. And corneal Pacumetry, the different ways by which you do and look at the corneal biomechanics also will determine how you are going to investigate a case. So not going into the theory, but just going directly into how to read the report is what we had talked about last time. So here, if you can you see my cursor? Can you see my cursor moving? Yeah. So on the left-hand side top would be the patient identifying information, the measurement summary window. So first of all, as we discussed last time, we should look at the age of the patient here. Date of birth would be there because we are comparing it with age-related normal database. And that will give you an idea about the age of the patient and what could be the likely diagnosis. Depending on the aspect that whether it would be keratoconus that you're thinking about or anything else. Then this whole red box which is there, that is divided has 4 different information zones. And then there is this 4 quad map. So this is basically 4 color maps. And last time we had discussed about the color indices out here. So the parameters which are given, you have to be careful to when you compare, especially that the indices are showing the same color. If you change this color scale, then the map colors would change and then you may think there is a progression. But before you compare 2 different reports, please make sure that you are looking at this scale and making sure that either it is every 2 diopters or every 1 diopter or 0.5 diopters. And that's the reason that basically doing it in the same machine with the same scale always has more value. Then the first map is used the axial curvature of the front, which will show you the different values which are there. So again, because these colors can change, it makes more sense to look at the values. Then the second one is the anterior float of, which is on the right side is showing, which is the best fit sphere. So when we talk about this, it is the elevation map that we are talking about. We had already discussed the best fit sphere. So I'll just show you a small animation next slide. Then the Pacumetry to see the thinnest pachy which is there. And it will also show the pupillary center and then the posterior float. So can anybody just tell me a few values what were discussed last time? Somebody who was there in the last class, when we look at the front, axial curvature front, what were the values that we spoke about? Anybody who was there in the last class? Hello?
Yes, you can volunteer.
Okay, so ma'am, in the axial or sagittal curvature front map, we'll be basically looking at the steepness of the cornea. And so the normal Ka values like K1 and K2, steep axis and the flat axis, we'll be looking at, and which would be 40 to 44 diopter.
Yes, very good. So basically around 42, 41, 42, 43 is what you would normally see. So anything more than 47 is, that's 47.2 is one of the values which starts to get suspicious. Anything more than 49 generally is an unstable cornea. That is one of the things that you need to remember. So can somebody else tell me the same way about the anterior float? So when we are talking about a best fit sphere, what we are trying to, so the cornea is not spherical, right? It's aspheric. So what is asphericity? I just need somebody to talk so that I know that some people are there.
Yeah.
When it's a virtual presentation and I am doing the slideshow, I can't see any of the faces here because the whole screen is with the slides.
Yeah, Netra or Mira? I think they know about that.
Yeah. Or Komal.
No, what Dr. Shivali is asking us regarding the Q value, what is the normal range, and
or what is asphericity? What do you understand by that term? Just say it. No need for values.
Normal means not the full sphere.
Can't hear properly.
Normal.
Normal?
The
cornea is
radius
not-
which is not same throughout in the whole circle. It differs from point to point. Like the like the center is more thinner and the periphery is thicker. So
Is it about thickness? When we are talking about asphericity, are we talking about thickness?
I mean, it's basically how the
We're talking
curvature
about
is changing.
Curvature. So we are talking
The
about
cornea changing
thickness
from the
here. We're
periphery to the
talking
center.
about it's more steeper in the center and it tends to become flatter as you go in the periphery. Okay. So it's the change in the curvature that we are talking about. So if we took a spherical sphere and tried to have a best fit sphere, which will have many of these points. So obviously being aspheric, some points would lie above and some points will lie below this imaginary sphere that you are trying to fit. Okay. So the ones that are above will have a plus value. The ones that are below will have a minus value. So when you are looking at the elevation maps, this for the posterior, anterior and the posterior, if you people remember the terms that you should use is that this is elevated by so much. It's here we do not say it is steep. So this is elevated by so much and this is depressed by so much. So these are the points that we look at. Okay, so in the posterior float, any of the elevation points, so if it is more than the best fit sphere by more than around 15, the plus 15 to 16 when you get, so that's when you start thinking that it is not a very, that could be an ectatic cornea, because that means it's going so much more steeper than the best fit sphere that you were able to fit. Okay. coming to the Pacumetry map. So here we have the thinnest value, and one of the things to look at is where is the thinnest value located as compared to the pupillary center or the apex of the cornea. So now all these three are three different things which you will come to know if you look at these left side parameters. All the left side red box that is there, I'll just show you that in the next slide. So this again, just to recap, so this is a astigmatic cornea. The steeper axis will have the hotter colors, the flatter axis will have the cooler colors. The eye would be written, okay, and then the apex of the cornea and the pupil will have a dotted circle, and whenever you're looking at this, whether the 2 points which are on the circle, 3 millimeter, 5 millimeter circle. So if you compare those two, that is the superior inferior asymmetry that we are talking about. So again, if both the axes have both the sides have the same amount of astigmatism, it gives you a bow tie, a regular bow tie astigmatism. Whereas if the astigmatism is different, then you would be seeing a different size of the bow tie here and a different size of the bow tie on the other side. And then the axis, so if this axis is straight or whether it is skewed is the other part that you need to look into. So it's like when you sing, you begin with do, re, mi, and when you read, you begin with A, B, C, right? So A, B, C, D, we just divide it into 4 parts out here. So the first part, we are told that the QS is the quality score or the thing that shows you whether the scan has been done well or not. So that should be okay. Another indicator is the box is usually in white background if the values are okay. So that's a very simple indicator. If the values are doubtful, then it would be yellow. And if the values have not been taken correctly, or if the patient has blinked, or the scan has not been taken correctly, then you would have a red background out here. Okay. And then this was the asphericity value, which we had discussed about. The normal asphericity value, again, if it is in that range, then again, you will have it in the white background. Okay. And that from there, you go to the K values, which are written here, K1, K2, which is the values which are given here. And this is the K mean. Whereas the other thing that you need to look into is on the C box, you would get the K max, which was the steepest point which is possible. Okay. The B section shows the same values what we discussed about, again QS and the asphericity, everything for the back of the cornea. Coming to this box C, then that is showing you the Pacumetry at the pupil center, at the apex of, and the thinnest local which is there. So what is more important is the thinnest local. So that is a circle and with a clear white center. And so that what you need to look at is this X and Y coordinate. It's a simple thing like your graph that you have. So the X and the Y. So if the Y value, if it is displaced much more than the normal what it should be, then that's when you get suspicious, because the thinnest local should be located close to the pupillary center and to the Pachy apex. And the last one is showing the anterior segment values. And one of the important things out here to look at is the AC anterior chamber depth, which is whether it is external EXT or internal INT is what you need to note. If it's external, then it is including the thickness of the cornea. Whereas if it is internal, it is starting from the endothelium and going to the anterior capsule of the lens. So these values and the internal anterior chamber depth is what is important when you are planning a phakic IOL surgery. Okay. So now this is another map which is just showing all these parameters. And now we'll just show you a few scans along with all these things that we were telling. Just want each person to just talk about it briefly so that we say what that scan is. Okay. And so this is the best fit sphere, and the Berlin-Ambrizio enhanced ectasia takes into account that, see, if there is some localized area of ectasia, then if you take an overall best fit sphere, then that is going to underestimate that area, because some area is above, some area is below. So you may not be able to pick it up. So what it does, it excludes the central 3 to 4 millimeters of the cornea, which could have the ectasia, and takes a best fit sphere. So then when that best fit sphere is taken, this particular ectasia gets very much enhanced. So that is how what it is doing is excluding that one odd area. So basically the outlier of the thing, and then you put a best fit sphere so that the one value which is outlying it will be very much prominent. And so this is how the normal bad display looks. So the upper left hand upper circle is showing you the normal best fit sphere, but this is the next one is the enhanced best fit sphere. And so the difference. So in this particular scan that I have shown, that enhanced also is normal. So this is a normal cornea. Even with having an enhanced best fit sphere, there is no ectasia which is coming in the third down scan. So this is for the front and this is for the back. The other three circles are for the back. And so along with that, you get the overall D scores, the differential scores which come here for the front, DF, back, DB, and then D Pachy. And then you have it for the thinnest Pachy and the Y, the how much the Pachy is, away from the center. And then along with all this, there is an overall D score, which is the last box that you need to look at. Again, if you see, generally speaking, white background would be normal, yellow background is that it's borderline, and the red background would show that there is a problem or an ectatic cornea. And you also need to make sure that you're looking at this graph. This is the thickness percentage change of the thickness. So if it is in the normal, in between these two upper and lower graphs, then it is again normal, follows that same curvature. But if it deviates before the 6 millimeter range, then it is abnormal, because it is thinning out abnormally fast. Okay, the change of the thickness, if it is happening before the 6 millimeters. So this is another, this was the normal bad display. And this one is showing you that the normal best fit sphere, if you were seeing it, you may have missed that there was any problem. Whereas when you have fit it with the enhanced best fit sphere, then this is what you are getting. And so you have a subtraction of these two. So the ectasia is being very much evident when you see it in the third map, which is down. Is that clear for everybody? This particular, how to read the Berlin-Ambrizio enhanced ectasia?
Yes, ma'am.
Because we'll be just showing you and saying, okay, is this normal or not? So if you're not clear, you can ask now.
Can you please tell me once more this particular one?
Did you understand this part? This screen that I'm showing you right now?
Yes, ma'am.
Yeah. So what is happening when we say best fit sphere? See, cornea can have different shapes, right? So if the left hand side, if I'm putting this kind of a best fit sphere, what will happen? This area will show that this is depressed, and the ectasia part, let's say it is showing plus X right here, but that is a smaller value. So I may not think it is a really ectatic cornea, because a little variation always happens, right? So if I use a enhanced best fit sphere, what it is doing is it is excluding that area of ectasia. Last time I had given the same example that if there are 10 students and if one student gets a 99%, let's say, and all the other 9 people tend to get around 50% to 60%. If you take an average of all the things, and if you say average basically, and you will be saying, okay, the class is scoring around 75%. But we will not come to know who is that one, outstanding student who is getting the highest marks, right? So if you say, no, let's exclude this one person, 99%, because he's totally different from the other people. And then you take the average, so that now the average is only 55%, because everybody else got between 50 and 60. Okay. And so now this one person who has got, okay, how much one person has got more than this? Then we say, oh, this person got 39% more. Okay. Am I clear now?
Yes, sir. Yes, ma'am.
Yeah, so that's why, so what we are trying to do is excluding that central 3-4 millimeters where usually the ectasia is. like assuming if there's an ectasia and fitting it to the rest of the cornea like this. So if there is no ectasia, you will not get anything here, right? Because we assumed that there is an ectasia and we fit another sphere. But if in that assumption, if you are getting some points which are now getting highlighted, that means we were missing it earlier. Clear?
Yes, ma'am.
So like in this, if I wanted to find out whether I'm missing something in this, so we excluded that central area and we fit a sphere. But again, even in that, the color scheme, see, it looks more or less normal. And this is a subtraction, that minus this. And so it is quite normal. Whereas in the next one, if you see, right, on the upper part, it is looking like it is normal. But when I have an enhanced best fit sphere, the ectasia is showing up slightly. Whereas if I say, okay, this minus this, then this much of values are coming. Okay. Can you see the values now? I'm trying to zoom in.
Yes, ma'am. Plus
Yeah.
9, plus 10.
Yeah. So this is the front. So any plus 9, anything more than plus 8 is suspicious. Same way in the back. Anything, see here, plus 15, plus 19. So I told you more than plus 15 is what is suspicious. So it is in yellow, and plus 19 is definitely going to be red. Okay. And this overall D score, so out here, this final value is what you will get. So this is calculating front, back, Pacumetry, displacement, everything, and showing you. So in this, so that's why, because outrightly it was not ectatic, but when we do this, it is we are seeing some ectasia. So the overall D score is in yellow, which is putting this in a borderline situation. Okay, so this may not be outrightly keratoconus, but in this kind of a patient, if you go and do a Lasik, then you may be causing it to become a keratoconus. Okay?
Okay.
Yeah.
Thank you.
Yeah, sure. So now, any one of you, please, just describe this. Only one or two will describe. Then we'll just go, okay, what is this? Which way do you want? Do you want to describe or just want to say what is the diagnosis? Spotters. Let's go fast so that the postgraduate can present their case also. Spotter, what is this? And at least 2 points to say why you are saying that, not just a wild guess.
Ma'am, it's looking like a keratoconus.
Yes. Just
Nasal. 2 points would be focal steepening in the axial sagittal map.
Yes.
Inferiorly, about 49 diopters. And the area corresponding to that in the Pacumetry map is showing 474, and the Pacu minimum is 460.
Yes. See?
Yeah.
Thinnest is 460, K max is 50.
Yes,
okay, 50 is definitely abnormal. 460 cone, you can see it. It's a left eye and it's a
nasal.
Yeah, nasal. Okay. So keratoconus. Clear cut ones only is what usually, you will be given like this. Usually they'll not give a very complicated pentacam. Okay. But you should not just jump into it. So the idea is to just say, okay, I'm looking at the first quad map, which is showing again, see, there is a steepening inferiorly in this one also, right?
Yes, ma'am.
Yeah.
So K1 being 45.2 and K2 48.2.
Yeah.
So 48.2 is again a bit outside the normal limit.
Exactly. K max being 53.2. Okay.
Yes, ma'am.
Thinnest local is 476.
476.
Okay. So just let's zoom into see the front showing around plus 19, right?
Plus 19 within the pupillary margin.
Yes. And here it is almost
minus 54, I guess.
No, that's plus.
Plus 50.
That's why. Plus steeper, right? Red.
Yes, ma'am.
Okay. So again, keratoconus only. Okay. Any doubts about this? advanced keratoconus, right?
Yes, ma'am.
I tried to put very, very obvious ones. 451, K max is 57.7. Huh?
Yes, ma'am.
Okay. And see, plus 73 here.
Plus
Okay.
73 of a posterior elevation.
Posterior, and the anterior is plus 39. We were talking about 8 to 10, right? So this is again keratoconus. Okay.
Yes, ma'am.
What about this? So every time you may not be just having a odd map display. Okay, there are different modes by which you could take the printout, and patient may get a different type of a printout. So don't get thrown away by, now this is not quad map. Okay. So again, try to look K144, K245.7. Huh? So
Yes, ma'am. Vacuum minimum 516.
yes, so
And we
not
see-
bad. Okay, it's above 500. But the Y is going to minus 1.18.
That means it's further away from the center of the pupil.
Exactly. So that is like a red flag here. So I mean, a thing that you will think that it is not normal. Again, these are the keratoconus indices, so which is shown. And sometimes this overall score comes out here in this box. Okay, but again, a couple of the values are all in backgrounds are in red. Okay, and when we leave to the anterior, as you see, some value is 50 here.
Yes, ma'am.
Can you see my cursor?
Yes, ma'am.
Yeah, and try to move. 39 here, posterior elevation.
Yes, ma'am.
Okay, so definitely this is, thickness is not yet gone below 500, but as far as the steepening is concerned, this is definitely a keratoconus suspect for me, right? And
Yes.
again, just by looking at the Pacumetry, so something that you should not be taking up for refractive surgery just because it's above 500. Okay. And just wanted to put a little different types of ectasia. So when you're getting the pentacam, it need not be only keratoconus which has ectasia, right? So these are 4 different conditions: keratoconus, okay, pellucid marginal, keratoglobus, and posterior keratoconus. So a very, very brief. So in keratoconus, can somebody tell me the main difference between keratoconus, pellucid marginal? It's all there on your screen. You can see the screen, right? Hello?
Yes, ma'am.
Yeah.
So,
So where usually is the thinning in a keratoconus?
inferiorly, inferior paracentral.
Yeah. But what I'm asking is in relation to the ectasia.
With the ectasia near the apex only.
Exactly. Whereas in pellucid marginal?
The thinning is
Inferior.
superior. No, inferior to the ectasia.
Yes. So can you see this here? Wherever it is becoming ectatic, that would be the area where you will have the thinning. Whereas when it comes to pellucid marginal, the thinning, the ectasia is happening and the thinning would be below that. Okay.
Yes, ma'am.
And keratoglobus, overall ectatic and thin. And a posterior keratoconus, the anterior is still quite normal, whereas the posterior, it is having an ectasia. Main difference. Is this clear?
Yes, ma'am.
Yeah. So how will this look in the pentacam? Okay. So just again, in one shot, I just wanted to show when it's pellucid marginal degeneration. So what is this called? A very classical thing.
Kissing bird sign.
Okay. Crab claw or a butterfly is the more
Oh, butterfly. Okay.
commoner. Yeah. Crab claw.
Crab claw.
Okay. The claws of the thing. So the steepening which is there. Okay. And whereas the thinning would be below that. Keratoglobus is like the thing is overall. Okay. And this flattening right in the flat and a thinner cornea in the center. So usually the center should be steeper, right? The moment you see center is going deep blue, that means you have to think about whether the procedure has happened. Okay?
Yes, ma'am.
Because when you do LASIK, what would you do is to flatten the center part. And anything which is irregular, obviously like a corneal transplant, if somebody has undergone a PK, DALC, okay, it will maybe multiple areas of suturing and all, which will cause it to be irregular. Okay. So what is this? Anybody? I just now showed you some examples. What is this looking like? Just now we described it. Yes, see? So you can't see each of the values, but you can see that there is a steepening which is happening like the crab claw pattern. Okay. Yes. What about this?
Post-Lasik.
Yes. So center flat. So post LASIK is a, you don't know whether it was LASIK or PRK, right? Yeah. So basically when you're not post refractive surgery is what we would say. This is post myopic LASIK. Again, myopic LASIK is what myopic or hyperopic is what you need to think about. But obviously central flat is post myopic refractive surgery is what this is looking at. Okay. What about this?
Post-transplant.
Couldn't hear you. What is this?
Post-PK.
Okay, if you think it's very irregular, but basically what's happened, it's flat, right? Yeah.
Post-LASIK.
But it is not so much in the center.
Decentered mark.
Right. So it's flat, but instead of coming in the center, if it goes slightly upper part, so what has happened is that it's a decentered ablation. Okay. This one. What is happening now here? Which area is flat? Which area is steep?
Superior hemisphere is
Steep.
The inferior, it's more likely to be keratolobus.
It's a little tricky one now.
And Terran's marginal degeneration.
Yes, one way is to say it's Terran's, but Terran's would be much more superior. It wouldn't come right till the visual axis.
Oh,
so again, this is a decentered ablation which has got corrected. Okay, so I should have told you that this is the thing, and then this is after you have corrected it because the ablation did not happen in the center. Okay, if it's Terran's, then again it will be that is a smaller band right in the superior. Okay, it won't come till the visual axis.
Okay, ma'am. Thank you.
This looking pretty irregular, right? Flat, but at different meridians, flat in different ways. That's the clue.
Post-PK.
Post-PK. Post-transplant.
Yeah, flat at different meridians. Talking about refractive surgery. Okay. Yeah, so now we wouldn't really see so much of it, thankfully, but we do get some patients even now who had RK done. What about this? Central steep, flatter as you go here, right? But it's not abnormal, 45, 46. Would you always only do myopic LASIK? And so basically when you do hyperopic LASIK, please understand what you're doing is creating an iatrogenic keratoconus. Quite sometimes your machine may say it is keratoconus because the center you are steepening and making the periphery flatter. But when that thing happens, you do actually get a Fleischer's ring kind of a deposition, because why does Fleischer's ring happen? We had discussed this last time and I said, is it exclusive for keratoconus? You remember? So that's because you can even get it in a post-hyperopic Lasik patients. Okay? Right. Are we looking at?
Is 43.
See, this is. Pardon? Who said? Somebody said something? Center is flat, right?
Yes, ma'am.
So post Lasik. So basically this was a femto-Lasik, but that we can't make out seeing the thing. It's just that I picked up different patients. So I'm putting the label according to what it was. Okay. So now again, this one, if I say that A is pre-op here and then post-op here, B is pre-op here and then post-op here, what is happening? Post-op here causing it to steepen.
Myopic Lasik.
Hyperopic correction.
Hyperopic. If we are causing it to steepen, it is hyperopic. Okay. If you are causing it to flatten, then only it's myopic. Okay.
Yes, ma'am.
What is this if I say that this first is pre-op, this is post-op, and this is the change which has happened after a procedure?
Keratoconus post C3R.
C3R will cause so much of a...
No, not this much flattening, but C3R will cause some flattening.
C3R will cause little bit, but C3R is mainly for only stopping the progression. When you are doing C3R also, that's very, very clearly you have to tell the patient that this is going to stop further worsening, but it may not change anything and you will still require some form of visual rehabilitation. Okay, when you're talking about keratoconus, the management is two pronged. One is to stop the progression and second is visual rehabilitation, which you will have to do with some other method. So this is actually causing a lot of flattening, right?
Yes,
so I'm giving you the hint when I'm telling you all this description. So what is that? What is this here?
Intracorneal ring segment.
Yes. Okay. So intracorneal ring segments, a single segment put in the area of the ectasia would cause a flattening. Right? So, and quite sometimes these are coupled either with the CXL before or after, so that the cornea becomes much more amenable to a contact lens fitting later. This may not really be a solution by itself. And now because the contact lenses, especially the spherical contact lenses, have become much, much better, we are doing less of the intrastomal ring segments. But one arena where this still stands out very well is a post-Lasik ectasia, because it's usually one segment is only what is needed and it will be rehabilitate the patient very well. So again, this is pre and post hyperopic refraction. Okay, so I don't know if you can see, sorry. So this is the pre-op and this is the post-op. That's why I showed you, because it's not in the sequence. So it will be difficult to say. Are you people clear about at least identifying pentacams now?
Yes, ma'am.
Yes, ma'am.
Yeah, so just going to the other part, which is the corneal biomechanics. The upper image just shows a normal cornea. So when a puff of air is put onto the cornea, there is a way in which it will show the movement. And when you record that and when you see, it is seen that the elasticity with which it will bend and come back, spring back to its normal, is going to be much more delayed and much more movement is seen, after movements are seen in the keratoconus cornea. I haven't been able to put a video here. So this is what is the corneal biomechanics. Based on this, when we are doing this, we have newer basically reports which are coming up. And when we are trying to see this dynamic corneal response and incorporate it with the pentacam, we get a further screening report, which is the Vinci-Guerra screening report. And there is an indicator called the Corneal Biomechanic Index. So when we incorporate this with the pentacam, what you get is a Corneal Biomechanic Index was 1. Then along with the bad score, Berlin Enhanced Ectasia bad display, what you said. So along with the CBI and the bad display, when both are combined, what you get is a Tomographic Biomechanical Index, TBI. So now these Corvus is getting incorporated with the pentacam that we did. And so you get this score. So this will be from 0 to 1. But the thing is, once ectasia is proven and you are getting it, then this value will not go anything beyond 1. So this usually repeating it for progression may not show you much, because once the ectasia is there, then the Corvus doesn't really help you to say that it is becoming or increasing. But at least for the normal corneas, when the so-called in one bad display, if you are seeing it is normal, but when you are seeing in the corneal biomechanical index, it may not be as normal. And so when you are taking this overall TBI into account, you may have a more suspicion or a red flag in that particular patient. The ASOCT, we talked about corneal Pacumetry, because obviously the measurement of the corneal Pacumetry is important. Whereas, so the normal ultrasound methods and non-contact methods, I'm not going into the theory of it, but just to show that this is a patient of CHED actually, okay, and where quite an opaque cornea, and still you are able to get with the ASOCT, measurement of the thickness can happen very well. So this is one of the ways which you can incorporate to say, take a better corneal Pacumetry measurements and incorporate that into the keratoconus indices or the ectasia indices. The other part that is important is that epithelial thickness mapping is also coming into play, because what happens when a keratoconus is in the early stage, that the epithelium may actually be a masking factor. It is like the cornea is getting thin at one place, but the epithelium may thicken at that particular place. So when you are actually just looking at the front, what you think is a normal curvature. Whereas if you can take an epithelial thickness map and just separate only till the epithelium, and the thicker epithelium area would maybe the area where actually the cornea is thinning out. So nowadays we have these subtraction tomographies, which can take the epithelial, the Sirius is one of the methods by which what it does is to take the epithelium mapping and then subtract from the original one. And so you are having a tomography which is from the Bowman's level, layer level. So that would actually show you a little, maybe some corneas which you are thinking is normal, with this epithelial thickness mapping and removing the epithelium, you may be actually coming to know that it's an early stage of keratoconus. So these are all there's a, one of the postgraduates was asking me just today that how are the methods by which you will, apparently a long question for you, to see the preclinical stage, or how will you diagnose a preclinical stage of ectasia or a keratoconus. So obviously the clinical signs would not be there, but in these investigations, maybe it would throw up a suspicion for you. So this is a patient, I think, yeah. So a patient who came from pre and post CXL, I guess is what I wanted to show in this. Right. Yeah. So this one, A is the post CXL, the latest one, and this one is the pre CXL one. So what has happened to the thickness? What happens after CXL?
Increased.
No, ma. This is the second one is the before one.
Okay, decreased.
Yes. Okay. Always whenever you see A, B, and A minus B, Okay, this third column is A minus B. So the first one that comes up is the latest scan, and the other one will be the older scan. Okay, so does that mean CXL is actually causing progression?
No, ma'am. It will strengthen the cross-linking bonds and thereby flattening it and looking.
Yes, so it causes the haze. And another thing is when pentacam is trying to see the thickness, because of the scarring also, there is a false value which it may say that it is thinned out much more than what it actually is. Okay, because the opacity which comes because of the haze will always give you a lesser value. So if you use any other method which is not optical, and then your values would be different. Okay, but this is what is, that's why you don't have to get worried. And so now that you have done the CXL, what you would do is to keep following up from this particular scan, which you do roughly a month or 3 months after the CXL is done. Okay.
Okay.
Right, and so this is, yeah. So this is the left eye of the same patient. Okay. So basically, this patient is from Bangladesh. We had done one eye, and then she went back, came, and she's done the. So now, one eye we had done. So left eye. I just wanted to show. So is there any progression here? .7, 57.7, 62.4, 63. So not much, right? Are you seeing this?
Yes, ma'am.
Yeah, so the steepening and the thinning is slightly there, right?
But when we are comparing thinnest local, it has actually increased.
Yes. It's not increased 6 microns, it's decreased by 6 microns, right? 406, 412. But again, may not be very significant, okay? But okay, what I was saying was just, yeah, so this was the values which the patient had when the patient came and showed the previous values done in Bangladesh. Is this visible? So when we compare with those values, okay,
then 447 has become 406.
Yes, so definitely there is a progression. So it's, when you compare with 1 month back what is done, it's not showing some much, but when you compare with the something that was done a little earlier, it is definitely showing a progression. And sometimes you have to take the decision based on the age, based on when the patient will be able to come back, that whether you would be cross-linking or not, right? Younger the age, more the probability of cross-linking, right? If it's a 10, 15-year-old at 11, 12, then more likely that it would progress. So that is the only situation where maybe even with the first scan and we are thinking it will definitely progress, we may think of cross-linking, not waiting for a second 3 months and then seeing that it's progressed and then only do the cross-linking. Right, so this one, 54, 57, K1, K2. Okay, I'm giving you the values. 448 thinnest local. K max is 67.3. Should we do something about it? Keratoconus, right? Everybody
Yes,
agrees, no?
Yes, ma'am.
Yeah, so should we do something about it? This is OD. I think we have, yeah, this is the same patient. Everything abnormal, right?
Yes, ma'am.
OS also. So OD more than OS, keratoconus. OS values also 48, 49 are K1, K2. K max 55. Thinnest local is 514 here. Okay. So should we cross-link?
Can progress. Left eye, we can, ma'am.
Left eye we can see, right eye we should cross-link.
No, ma'am. Steve, K-max is too high for cross-linking, ma'am.
Let's go back. K-max is too high for cross-linking. What would be, why would you not cross-link? I mean, what is your criteria for cross-linking? Is your cross-linking machine not going to work? Okay, so the thing is not that the cross-linking cannot be done, but the idea is to see how much vision the patient has and then decide whether cross-linking is going to help this patient or not. Not this particular one, I'm just telling you in general. Because if you cross-link also, and if it is a very, very steep K, which is not amenable to correction with contact lenses, then you have to rehabilitate the patient in some way. And so in those situations, maybe doing a DALC may be a better option, because you have to rehabilitate also. Okay, but you would be surprised that quite some steep case can be corrected with scleral contact lenses now. So in any such patients, what you would do is to have a contact lens trial, scleral contact lens trial, and see how much the patient is improving, but don't give the contact lens, cross-link the patient, wait for at least 3 months, and then have a repeat contact lens fitting, and then give the lenses. Okay. But this particular patient, we are at the end of the class, so nobody is thinking it could be a trick question. I had told you, start from looking at what is the date of birth, what is the year. "50-year-old patient this is," okay? That's the reason I put it up. Before you think of doing something, look at the date of birth. This patient is pretty stable, okay? So it all depends on the clinical thing. So you cannot tell anything just by looking at the pentacam. That's what you are supposed to say if you are asked such a question. That you are supposed to look at the date of birth and say this is a almost 50-year-old patient. So depending on what the vision is, we have to see. But basically, because it's 50, we are not really thinking it will progress, right?
Yes, ma'am.
Yeah. So before you jump to doing something, always understand that you need to see clinically and say that I would like to see, and I would like to know what is the vision of the patient, and I would like to see whether this is progressing or not. Considering that it's 50, it may not be progressing, and if the patient is rehabilitated, we may not have be doing something about this. Okay. So that is just to come back to the fact that clinical examination, nothing will replace a clinical examination. This is a very, very favorite lines of which I keep telling almost in every class which I try to take the postgraduates, that too much zeal for the new and contempt for what is old, from putting knowledge before wisdom and cleverness before common sense. Okay, from making the cure of the disease more grievous than the endurance of the same. So please make sure that you're looking at the patient as a whole, not just one report, not just one eye. If somebody asks you to look at one eye and give a diagnosis, slit lamp, and say, tell me what it is, please say, I want to look at the other eye. But just by looking at one eye, this is what I think it is. That is what the examiner is looking for when he's saying, see right eye and tell me what it is. Okay. Thank you for your attention. And
Thank you, ma'am.
I'll stop sharing now.
Thank you, ma'am.
Yeah. Yeah, thank you, Srivarli, for that exhaustive, very elaborate discussion on keratoconus. I think it was a bit slightly heavy for us, our postgraduates, because they are basically residents and they have just moved into the second year. Anyway, great job. So shall we discuss some topography images here? You can run through that. I think maybe 15, 20 minutes, nothing more than that.
Okay, so I'll just start sharing.
Yeah.
Yeah, I hope at least people understood and got an overall idea about it.
Yes, definitely, ma'am. It was very nice, actually. We skipped through many cases and went through overall parameters and got to know a lot
Yeah,
more.
at least you have an idea that now you know you can be shown a post refractive surgery, or you can be shown. Just that's why I just want you to identify this could be normal, abnormal, what. Don't go into the indices and the values so much. Okay. Yeah, please go ahead.
Sir, should I start from topography images or pentacam?
Okay. I think for the benefit of other postgraduates, I think we can discuss these two, maybe then go back to other ones. Maybe somebody, Gargi or someone can volunteer to comment on this. Gargi, you're not there?
Otherwise, I can.
Yeah, you can do it. Yeah, fine.
Okay, so it's a pentacam chord map of a patient who is about 29-year-old,
Okay.
and it's the right eye being studied. The K1 is 42.3 diopter, and K2, the steep K, is 45.5 diopter, with an astigmatism of 3.2 diopter, plus 3.2 diopter at 72.8 degrees. This is about the front aspect of the cornea. Back aspect of the cornea, K1 is minus 6.1 diopter. K2 is minus 6.7 diopter, which is well within normal limits. Then astigmatism is again 0.6 diopter, which is also fine for a posterior surface astigmatism. Then coming to the Pachy at the center of the pupil, it is 540 microns. And the Pachy minimum, or at the local point, it's 515, and x-axis is at minus 1.73. That means it is deviated a lot far away from the vertex, so which is a bit abnormal here. And coming to the axial sagittal curvature, front curvature map, what we see here is an area of focal steepening outside the central pupillary zone infranasally, which is corresponding to 47 diopter here, followed by some area of flattening also, which is more temporally. Like the difference, if we divide the cornea into equal halves, maybe 90 to 270 degrees, you can see that this side of the cornea is on the steeper side, and this side of the cornea is on the flatter side. That means 47 and 37. So that's about 10 diopter difference here. So we'll be moving to the next map, which is front elevation map. Front elevation map is about +4 in the center of the pupil, and superiorly it is +7, inferiorly +9. If we compare the points that we discussed after dividing the cornea into the half vertically, it is minus 26 diopter of depression at the temporal side, and +10 microns, sorry, not diopter, +10 microns of elevation on the nasal aspect, which is okay. Yeah. Then coming to the corneal thickness Pacumetry map, the Pachy local is lying outside the pupillary margin, more towards temporally. Sorry. And Pachy minimum at the vertex is 540 microns here, and elevation back. Coming to the elevation back map, it's +1 of elevation of the back surface of the cornea, and -15 and -16 superiorly and inferiorly. This is about the quad map.
Yeah, is there any, I think you're seeing that the cornea is very asymmetric. One half of the cornea is very different from the other half.
Yes, sir.
And interestingly, the curvature, the axial curvature is not corresponding to the area of thinning as well as the area of elevation.
Yes, sir.
That's what we make out. Okay, so that is one thing I just wanted everyone to know. Because if it is something like a keratoconus, you generally expect that the thinnest pachy, the area of elevation, and also the increased curvature, that area all corresponds. So that is exactly not seen in this particular map. Actually, in the area of maximum curvature, what you see is?
It's about 853 of pachy.
Yeah. Yeah. So that is almost 853. Yeah.
So 853 is a bit more further away, but it's on the yellow side, it is 580.
Okay, fine. So let's go to the other map, bad map.
Okay. So in the bad map, we can see the K1 to be 42.3 diopter, K2 to be 45.5 diopter, with the flat axis lying at 72.8 degrees, K maximum of 47.1 diopter. Then the minimum local pachymetry is 515 microns, and the front elevation thickness is minus 18 microns, and back elevation thickness is 13 microns. Progression index, it is minimum 1.2, and average is getting way outside the normal limit. That's why it's shaded in red. The difference, if we talk about DI and DB values, it is 4.02, that is the DI, and DB is minus 0.75. D posterior is 6.75, and D total is coming out to be 0.68. The front elevation raw data, we'll see about them. So for the right eye, front elevation is about +2 and minus +2 at the center of the pupil, +8 superiorly, and +8 similarly inferiorly. But if we look at the area that we were concerned about, here it is a depression of -23 in the raw data map here. That means that this area is depressed when compared to a sphere. And comparing to the sphere will be the next. I'm sorry.
Yeah, I think we should look at the fellow eye also. Before you make a diagnosis, we should look at the fellow eye also. Can you show the images of the fellow eye?
Yeah. These are the bad images of the fellow eye, sir.
Now, can you show the quad maps? So yeah. Can you just explain, Yash, what it is?
So the other eye, it's K1 of it's the left eye. First we saw the right eye. Left eye K1 is 37.7 diopter, which is way below the normal level of the corneal steep axis, and corneal steep axis here is 39.4 diopter, and the flat axis is at 21.2 degrees with an astigmatism of 1.7 diopter, and cornea back curvature, it is -5.9 diopter, and K2 is -6.6 diopter, both of which are within normal limits. Then pachymetry, coming to the pachymetry map, at the center it is 475 micron, and the pachy minimum, local minimum, is not much far away from the vertex and is not much different from what is at the vertex. It is 472 micron.
So yeah, you, rather than just the values, also tell what you think is happening here.
It's basically more of a flat cornea.
Yeah, flatter in the center.
Flatter in the center, and a bit on the higher, steeper side.
Again, flatter in the center is not the normal way cornea is. So yes, what must have happened?
Could be a post-refractive surgery.
Exactly, and thinning out in the center also.
Yes, ma'am.
Right. So yes, with this, maybe go back to the right eye. That's why Dr. Anil was saying. So now if this is post-refractive,
yes, ma'am,
then go back to the right eye.
Then in that case, this looks like a decentered myopic Lasik patient.
Yeah.
With the decentration more towards temporally.
Yes.
And this is a compensatory steepening of the nasal side.
Yeah, not a compensatory steepening. We don't know how the cornea was to begin with, right?
Yes, ma'am. Yes, ma'am.
So now we ask Dr. Anil whether we are correct or not. Anil?
Yeah. That was a post-refractive surgery patient who came for a second opinion.
Yeah.
So, one person had suggested post-Lasik ectasia, even though it was very early in the post-operative period. But obviously, it was not looking like, because the Pacumetry map is different. The posterior elevation is perfectly normal. Actually, the front elevation map also, on the it is not corresponding to post-Lasik ectasia.
Yeah, it's not an ectasia, but basically maybe it's a decentered
Decentered
ablation.
Yeah.
So we just need to wait and see whether this is going to become ectatic. But as of now, the patient's problem may be that the refractive correction may not have happened fully. And so maybe left with some residual cylinder because of the decentration which has happened.
Yeah.
Right.
And the patient is obviously unhappy because
Yeah.
she was having a lot of refractive error, residual refractive error.
That's a totally different class altogether, an unhappy refractive surgery patient. Yeah.
Okay.
So that's why, so see, when you look at the other eye, this becomes clear. If you just look at first this eye, it's a little confusing, right?
Yes, ma'am.
Good case.
Yeah.
So somebody else now? Fast.
Yeah. Gargi is there? Or Mira? Please do the honors.
This is a pentacam image of a 18-year-old patient, pentacam image of right eye, with the cornea front, the K1 is coming to be 43.1, and which is the flat axis, and K2, which is the steep axis, is coming to be 46.3, then astigmatism of 3.2. The cornea back also, K1 is coming to be minus 5.9, and K2 6.5 diopters, which is the steep axis, and the astigmatism is 0.5, which is normal. Moving to the Pachy, the Pachy center is coming to be 471 microns.
You didn't comment about the quality score, no?
Quality score is okay, and asphericity is, I think, minus 0.28. It's actually not visible. It's just
minus 0.28.
Minus 0.28, which is also within normal limits.
Okay. What is the normal? We didn't talk about the value last time. This time I didn't tell you. Last time we had talked about.
Plus 5 to minus 5. No?
Plus?
Asphericity.
Plus. Why are you missing points?
Plus 0.5 to minus 0.5.
So, yeah, 0 to minus 1. To be broader aspect, 0 to minus 1 is the asphericity.
Okay.
Okay?
Yes. Pachy center, it is 471 microns. And thinness locus, at the apex, the Pachy is 473, and thinness locus 464, which is within normal limits from the apex. That is minus 0.68 in X coordinate and minus 0.88 in the Y coordinate. And the Kmax is coming to be 46.5.
Okay. 0.88 is slightly suspicious. It's more than 0.5. Y coordinate is slightly deviant. Not too much, but still.
Up to 1, will we take normal or a point?
Yeah. More than 1 only, you can take it as pathological. But
anything more than like 0.5, you should have to be suspicious.
Okay.
0.5. Y value 0.5.
0.5. Coming to the axial sagittal curvature map, there is a symmetric bow tie pattern can be seen.
What pattern?
Symmetric bow tie pattern.
Okay.
And moving on to the front elevation, it is +3 within the pupillary area, which is within normal limits. And back elevation is coming to be +22 outside the 3 mm pupillary area.
So is it normal for an astigmat?
Yes, sir.
Yeah. So this is a saddle pattern that you see.
Yes.
It's normal for an astigmat. Okay. Yeah.
And coming to the corneal thickness map, in the thinnest local is coming to be 464, and at the center it is 471. So it's lying at the 470 is the normal real tell.
Quite sometimes you do get thin corneas, which need not always be abnormal. So this looks like a
Patient with
portrait stigmatism. So it's like a normal astigmatic cornea with a thin cornea as of now, right?
Yes.
Yeah. So we should look at the bad indices.
Yeah, so the other eye is giving you a little different picture. I think that's the next one is the other eye. Yeah, this one.
So this is the pentacam image of the same patient with the left eye with the quality score okay, and corneal asphericity -0.52, which is also within normal limits. And the cornea front, the K1 is 43.2, and the K2, which is the steep axis, it is 47.8. This slightly above the normal value, slightly abnormal, slightly suspicious. And the astigmatism is coming to be 4.6 diopters.
And look at the Kmax.
Yeah.
The Kmax is 49.8, which is abnormal.
Definitely abnormal.
And the
thinnest cornea also.
It is thinnest local is 449, which is also suggestive of a.
And the astigmatism itself, the first quad map, what is it? The first map, what is it telling you?
It is a asymmetric bow tie pattern.
Yeah. With a slightly
more inferior.
Yeah. So those 2 points which are lying on the two ends of the 3 mm when you are trying to compare. So how much of an asymmetry would you think is abnormal?
More than 2.5?
2.5, more than 2.5. Okay.
Oh, yes, ma'am.
And the skewing?
22.
Yes, around 22 degrees, right?
Yes, ma'am.
Okay, good. Yes.
Yes, sir. Should I move on?
Yeah, I think we don't have too much of time, but you can show one of the first few images, Yeah, show that.
And the same way, the asymmetry, the way you talked about 2 different points, about Pacumetry also, can you tell something, any one of you? Corresponding points in the Pacu map. So any difference which is more than 30 microns should be suspicious. Okay?
Sir, ma'am, if it's Pacumetry minimum less than 470 with normal topography, then it's known as a thin cornea. And if it's less than 500 with abnormal topography, then it's known, we consider it as a thin cornea, ma'am.
No, I didn't get you. Can you
Ma'am,
repeat?
if there is an abnormal tomography with the less than 500 micron, then it's an thin cornea, no, ma'am? Even if it's just less than 500.
So if you have an abnormal tomography, if you have steepening, if you have ectasia, then even if it is not less than 500 also, it can be keratoconus, right?
Yes, ma'am.
Only one point will not tell you whether it is keratoconus or not. You have to put together all the points together and then give your diagnosis. Okay. It's not just that only which are less than 500 will be keratoconus. You can have keratoconus which is still as of now more than 500, but it may progress in future, right?
Yes, ma'am.
Yeah, and you can have sometimes 460 kind of a cornea which is normal. There's no steepening, there's no ectasia. It could be normal thin cornea. But the idea is you have to identify these, and you should very thin cornea, so you should not be doing any refractive procedures which may cause further problems. Okay.
Yeah, Gargi, what Dr. Shivali was telling us, if you look, you should look at the corresponding points.
What I was talking about was the like superior and inferior, the way asymmetry you told in the first quad map, no, axial map. You're comparing 2 points which are like roughly in the 3 millimeter zone above and below, and saying any asymmetry more than 2.5 cylinder is what we say is 2.5 value. So if one is 44 and if the other one is 47, then we are saying it is the asymmetric bow tie, isn't it?
Yes, ma'am.
The same way in the Pacumetry map, if you are having corresponding points above and below that center point, which is 30 microns in difference. Basically, if the center is thin and then it is thickening as you go, superior and inferior, it should be the same amount. If there is any disparity of 30 microns above and below, then that's again a suspicious cornea, basically a report.
Okay.
Okay. Yep, please proceed.
Yeah, Yesh, can you describe this?
Okay, so it's if we talk about the steep axis, and steep axis is of 45.27 diopter at 83 degree, with a flat axis of 43.27 diopter at 173 degrees, with an astigmatism of +2 diopter at 83 degrees, and mean keratometry value of 44.27 diopter. Coming to the anterior axial curvature map, the anterior axial curvature map is suggestive of a bow tie, symmetric bow tie pattern, which is in with the rule, like the steep axis is at the 90 degree, and the corresponding values that we can find out from here is about 45.5 as per the color coding. It's corresponding to that, and flatter axis horizontally. This is the anterior axial curvature map. Then also coming to the Pacumetry map, within the central, this outer circle is basically the pupil, and the center one is your 3 mm zone. So the basically the 3 mm zone of the pupil, 3 mm zone of the central 3 mm optical zone of the cornea is having almost the same color scheme throughout, and which is corresponding to about 530 microns, and Pachy minimum being 529. So it's well within normal limits. Relative pachymetry is corresponding, it's almost again the same shade between the central 3 mm optical zone, and it's about -2, which is okay within normal limits, ma'am. Then anterior elevation, just a minute. Anterior elevation after spherical correction is suggestive of depression superiorly and inferiorly, and this part of the horizontal part of the cornea is lying with the sphere, so it is matching the curvature of the sphere, and posterior elevation is again superiorly and inferiorly depressed, and the horizontal portion is again with the sphere. So this is basically a normal with the rule astigmatism.
Yeah, so what are the types of astigmatism?
With the rule and against the rule would be one, then mixed, and
mixed would be?
Oblique.
Oblique astigmatism is when the vertices are not at 90 degrees to each other, and mixed would be one eye hypermetropic, one meridian hypermetropic.
So when you're saying mixed astigmatism, what you're talking about is a different classification of astigmatism. When you are saying it's a simple myopic astigmatism, compound myopic astigmatism, simple hyperopic astigmatism, compound hyperopic astigmatism, and then comes the mixed in that classification.
Yes, ma'am.
Okay. So there are different ways by which you would classify astigmatism. One of this is this, and then you would say regular and irregular. So all these what you talked about right now are in the regular astigmatism.
Regular astigmatism.
What is biooblique astigmatism?
Biooblique.
Yes.
When they are not having 90 degree between the axes.
When good. So it's a regular type of astigmatism when you can discern the astigmatism into two axes. Okay. So that is what is a regular astigmatism. When you get it into more than two axes, then that's what is the irregular astigmatism. So when both the axes are at 90 degrees is the usual with the rule against the rule. And when it is not at 90 degrees to each other, but not at 90, 180 is what is oblique. But they are not at 90 to each other. So one is at 110 degree and one is at 30, and there is 90 degrees, let's say. That is what is a biooblique astigmatism. Everybody is clear on this?
Yes, ma'am.
Right. Good. Proceed. So Anil, that was basic because you said we are going to high.
Yeah.
So I thought let's go back to Duke Elder then. I hope you people read Duke Elder, do you?
No.
Reflection? Okay, proceed. Who hasn't yet spoken in the class?
Netra.
Yeah, please. We want to hear everyone's voice.
This is the corneal topo of the left eye showing a steep K at 46.16 diopter at 101 and flat K at 55.33 at 11 with astigmatism of +3 diopter, and the anterior axial curvature showing different colors in the central 3 mm with around the steepest around 46.5 to 47.5, the steepest area being around Paki, central 3 mm showing around 530 with the Paki minimum of 525 micrometer, and the anterior elevation showing around relative Paki around minus 6 microns, and the anterior elevation showing around 5, and the posterior elevation around the steepest around 15 in the posterior elevation. This
no, in the central 3 millimeter, it's normal. No, it is
central 3
0 to 5, within 0 to 5. Now, for the people who are not used to this vicinity, I will just say that Pacumetry Map. Basically, you have to look at the central 3 mm zone, whether more than 3 colors are coming. Other thing is relative Pacumetry. So once it anywhere between 9 to 12, anything more than 9% difference would be significant. 9 to 12 would be borderline. Anything more than 13% is considered abnormal. So based on that, I think we would term it as perfectly normal, because in the central, even the 6 millimeter area, you can see that it's not even cross 5%. So it's perfectly normal. Pacumetry map, anti-elevation and post-elevation map is perfectly normal, while the axial curvature map is showing a slight steepening more in the superior part. And it is something like an asymmetric bow tie, though not perfect in asymmetric bow tie. So this is just a superior steep pattern. So this is a normal topography. Right?
Yes.
Yes, sir.
Yeah. Yes, next one.
Sir, it's going to be 8:30 now.
Yeah. I think this would be the last one. This would be the last one. Yeah. Who would like to?
Gargi has to present.
So
Yeah,
this is the
yeah.
Pacumentary of the right eye with the steep axis at 46.66 at 87 and flat axis at 43.64 at 177 with the astigmatism +3 at 87, which is with the rule astigmatism. Coming to the Pacumetry, in the anterior axial curvature, it's showing symmetric boat shape pattern. With the Pacumetry, coming to the Pacumetry, it corresponds to 600 in the central 3 mm zone, and the relative Pacumetry is around 4, which is within normal limit. Anterior elevation corresponds to 15 and posterior elevation within 3 mm corresponds to minus 20. So there is a steepening on the superior, superiorly there is a steepening, which might be because of the cataract surgery, sir.
So we should know the background of the patient also in such a patient.
Yes, sir.
Okay, so this patient, I think I just put a
small diagram.
Yeah.
In the upper quadrant, like it was an SICS, wherein 2 sutures are put at the main section and 1 suture at the side port.
So generally, what do you expect when you have a superior scleral incision?
Sir, in the old age, there is usually against the rule astigmatism, but if you put the superior incision, there will be the astigmatism more with the superior steepening with the rule astigmatism.
Now, what happens if you put a superior scleral incision? What will happen?
Basically, what does your incision do?
Yeah.
Flatten the cornea.
Whenever you do cataract surgery, if you put your incision, what is that going to do?
Flatten the cornea.
Yeah. So in this case, you don't see flattening. What is that you're seeing in the meridian? You're actually seeing steepening. So what could that be? What is it due to?
Tight sutures.
Yeah. Okay.
So that's why you would plan your cataract surgery with a in the steeper axis to put the incision. When you move to doing cataract surgery to that level that you want to minimize the astigmatism, even if it is if minimal amounts, if you always try and place it in the steeper axis. Okay.
Okay, ma'am.
But SICS, when you do that, what is the thing about frown incision?
Frown incision would
causes more astigmatism. No, sorry. Frown incision causes less astigmatism.
falls in the astigmatic
because it falls in the
astigmatic funnel.
Funnel.
Yeah. So, what is the name of the funnel? Your homework.
I think our Dr. Gopal is back. He has reached Cochin, I think.
Oh my God, he was outskirts somewhere.
Yeah, yeah.
Okay.
He was about 70 kilometers away.
Oh.
So our class extended so much that Gopal could make the continuum walks.
It's a good case to end with, just to show you that you don't have to think that we are postgraduates and we, all this pentacam and refractive surgery, all this is beyond us. So it's okay if we don't understand. Don't think that, because see, that's why Dr. Anil has put this simple case of SICS done most likely by one person like you, and so this will cause changes. So when you are doing even a simple procedure and when you are starting your cataract surgery, please try to understand all these aspects. And when you look at it, at your case, pre-operatively, post-operatively, do your keratometry, which is the simple way of knowing your astigmatism, and then you will be starting to understand all these images that we are talking about. Okay?
Yes, ma'am.
Always start with the simple things that you're doing. See every patient with that aspect in your mind, and then you'll start picking up many more findings.
Okay.
Right. So,
yeah. I think we are
fruitful 1.5 hours.
Yeah.
It was, Anil, I'm sorry I missed it.
Yeah, that's fine. Okay. Okay. So thank you, Srivarli. Thank you so much for spending so much of your personal time. And your presentation was very exhaustive, and it carried a lot of points for all the residents. Thank you so much again.
Thanks.
Thank
Thank
you
you
so
for
much, Srivalli.
inviting me.
On behalf of Kerala Society of Ophthalmic Surgeons also, not just in Anil's behalf. Thank you very much for coming twice.
No, that's
again for a cornea case.
yeah. Yeah, thank you. Thank you for calling me. It's always a pleasure to interact with postgraduates. I used to be in the teaching faculty much more actively when I was back at LV Prasad Eye Institute. So it's always good to get back to the basics and teach. Thank you. And all the best to